Okay. So, good afternoon to all of you, and it is a pleasure to be back again on Midstream 360. I am Dr. Praveen Chandra from Medanta Medicity Hospital here in Gurgaon, India, and along with me is Dr. Abhinav, who is going to be in this case today to take it forward. So, this is a very interesting situation, and he is going to tell you about the clinical history of this patient.
Yeah. Hello, everyone. So this is a 66-year-old female. From last 3 months, she had significant angina, which was managed medically earlier, and she underwent angiography as well. Outside, she was kept on anti-anginals, maximum optimum therapy, but despite that, she had significant angina. She has comorbidities in the form of diabetes, hypertension. She
Bad
had
lung
OSA,
disease.
a bad lung disease as well, COPD. And so here we started with the angiography, and it revealed the same thing, having the circ having almost 70 to 80% distal lesion, LED having almost 80 to 90% mid lesion. So it is a fibrotic lesion along with some calcium inside. As we have tried crossing the IVUS in the LED, but it was not crossing. Now, sir will forward the case.
Okay. So here you see that on angiogram we have a long disease in the LAD. There is a disease in the first OM, which is a very big OM, and then the distal circ is having some narrowing in the range of about 50-60% and maybe up to 70% at some places. And the right artery is non-dominant, but it is having some disease. So here, next, please, next.
Next.
So in this, you can see that that LED is the tightest lesion, which is creating this symptom. And she has been, advised surgery earlier in many institutions, and then she was seen by some surgeons, but they all refused surgery because of her bad lung disease. So then she was brought here, and now we see that the LED is the culprit lesion, but certainly we also need to look at the circumflex and the OM. So next slide, next. Okay. So here you can see next. Yeah. So here you can see that we have wired the LED, and also now we will assess that whether this OM and the circumflex is significant or not based on the FFR. So we have put the wire in the OM, as you can see here, the first big OM, and this wire is in the first big OM, and the IFR values, as you can see, is 0.97, 0.95, which is clearly normal actually. Although on angiogram it was looking like at least 70%, 80%, but it is absolutely okay. So we don't need to really touch it, because if we have to touch it again, there was an issue whether we should have put a stent, but we had planned to do a cutting balloon and a drug eluting balloon in case we had to intervene. But it is very clear that most likely not. But now we will go ahead with FFR. So many times when we have a negative IFR, we go ahead with FFR. And I'm going to inject adenosine now. And this is 200 mics of adenosine. And you will see some bradycardic effect. And here we have some bradycardia. Okay. So how much is the FFR? Let's have a look. So the FFR is still 0.88, 0.87, and the FFR is also negative, clearly negative. If you look at the screen, it is clearly negative, 0.85. Yeah. So we are fine with this OM at least, and maybe we can put this wire into the distal circumflex and see how it is going. So can you just check now? Okay. So I'm pulling the wire back from the the OM, and I will use the same wire to see if circumflex is significant or not. Check, please. No, I can't see
Distal.
anything.
Distal. Right.
So we have put the wire in the circumflex. Yeah. Okay. Yeah. Okay. So let's look at the values here. This is significant. Okay. So this value is significant here. As you can see, that it is coming to about 0.6. So this lesion in the distal circumflex is definitely significant, and we might consider to do a intervention here because this is the IFR and it is 0.56, zero point 0.6, which is definitely significant. So the OM, which was looking more, was negative, and here we have the distal circumflex where we were not very suspicious. We see, but of course, we saw that it is a long lesion. So this is a long lesion behaving like a tight lesion now, and we will definitely treat it and see how it goes. But now the thing is that the first lesion we are planning to treat is the LAD.
LAD.
So we will leave this wire here for a while and start treating the LAD first.
2.25, 15 balloon.
So the plan is to do a epicranial, please. The plan is to dilate this LAD first with a normal balloon, high pressure balloon, and then we will see. Is 2.25 into 10?
2.5, 15.
15. Okay. So it's a 15 millimeter balloon. And now the question is whether we should put a stent in LAD or do a drug eluting balloon. We will decide. Okay. So here we are with the balloon in the LAD. Okay. Yeah.
Hmm.
Check, please. Take a shot. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8. Deflate. So you saw that the balloon moved a little bit, slipped down because of the long lesion here. Go up. 1, 2, 3, 4, 5, 6. Again, it is slipping. Deflate. Okay, check, please.
Just a second. Here.
So it is a very fibrotic kind of lesion. Check a little bit. No, I'll put it be here. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate. Again, it is moved. So you can imagine how fibrotic this lesion is. Go up. 1, 2, 3, 4, 5, 6, 7, 8. Now it is staying a little better. 12. Okay. Deflate. Okay. Take a shot. Okay. Okay. So this is the time we can do IVUS now.
Yes.
Although, and maybe some more dilatation here in the distal part because that balloon didn't stay there. Go up. 2, 4, 6, 8, 10, 12. Deflate. Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate.
Proximally, there was also in IVUS here.
Check, please. Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate. 12. So we are doing serial dilatations in this entire length of the vessel. Deflate. Using 2.25. Yeah. Yeah. Yes. No, I cannot see the questions. Somebody has to read it out. Yeah. Okay. I'll ask someone to do that. Ask someone to. So can you read the questions and tell me? Questions, please. Okay. Okay. So I'll ask my colleagues to do that and then I will answer. Okay. So let us do IVUS now. So we'll do an IVUS. Okay. So this is a IVUS run we are going to take for you and bring it forward. Okay. Fine. So I'm in the normal segment of the artery And here again it is okay. Okay, where are we right now? Okay, can you do a check shot? Yeah. Okay. Yeah. So here the artery is looking normal and the size is about 2.5 distally. Some calcification here also. Yeah. So maybe it will be better to do a cutting balloon over here. Here the lumen is small again, not too small. And here is a normal segment. Okay.
2.5.
So we can take a 2.5 millimeter cutting balloon, 2.515 please, and do a cutting balloon here to see how it looks. And if we are able to get a good lumen without any major dissection, we might consider doing a drug eluting balloon also. Okay. Show me. Mm, yeah. So this is a Wolverine 2.515.
Yes.
Yeah. So this is the FFR. There is a question here. Which FFR system? So this is the Volcano Phillips FFR system which we are using. It gives a value in IFR and FFR both, and it is the same integrated equipment which we have for use for the intravascular ultrasound. IVUS, same. Check please. Okay. No, there is no Indian company which makes FFR devices as of now. So here it looks okay. The position of this balloon is okay. Yeah. What was the? Okay, this is a BMW wire. Go up. BMW wire in the LED and the FFR wire in the
Go up.
go up 2, 4, 6, 8, 10, 12, 12. Okay. So here we are dilating with it up to 12 because there was some calcification. Well, 13, 14. 14. Okay. Deflate. Any other questions? Okay, yeah. So the depth we are planning to use is actually made by Med Alliance, which is and now it has been taken up by Cordis, and this is the balloon is known as solution
Six,
balloon.
six,
Go
eight.
up to 4, 6, 8, 10, 12. 12. So now you can see that with the cutting, the balloon expansion is much better. Deflate. IVL definitely in this case probably is not will not be required because the calcification is not too much. Check please. So that is why I'm just using the cutting balloon and not the IVL. Go up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Deflate. So nice questions. We will be answering more questions if required. So please let us know.
Proximally.
Proximally, we don't have to. Okay. अभी हटा रहे हैं मास्क हटा दो Okay, check please. Check. Okay, go up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16. Okay, deflate. So at 16, it almost becomes like 2 point, how much? 75,
2.75.
2.75, 2.8. Check now.
And this
Okay,
point.
go a little bit back. Okay, go up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16, 18. Okay. So this is a Wolverine cutting balloon going up to 18 atmospheres. Deflate. Deflate. So we have done serial dilatations. ये बस ज़्यादा मत inject. Okay. Now we will see whether we have to do any more dilatations or nothing, or just two more stents. Okay. In
At
fact,
bifurcation,
this looks quite good.
at bifurcation, there is some
Yeah,
defect.
there is some dissection there at the bifurcation with some luminal effect, maybe, but otherwise, this vessel is very well dilated now.
Hmm.
Yeah, but I think we have to stent it. So we'll take a long stent,
44.
48, maybe. Yeah, 48. So give me a 48 stent.
IVUS shoot.
Yes.
I, this is
Uh,
tracking.
there is a question that an Indian manufacturer makes cutting balloons or not. There is no Indian manufacturer who makes cutting balloons right now, but
43.
certainly stents are being manufactured in India by several companies.
Okay, this way.
Yeah, okay.
2.548.
Not really, because as I said already, that the calcium was not that much. It was mainly the fibrotic part of this
49.
lesion, which responds better to cutting balloons and Wolverine like cutting balloons.
Maybe
Yeah.
this is 33 and
Uh,
approximate 15. 50.
uh,
49.
49, 50.
Side branch axis. And
Mm. Yes, yes, certainly. We will use IVS at all stages. We have done IVS before, and now we will even do it afterwards. So here they have a 48, but it appears that 48 will be just about or maybe a little short. So we can use
49.
maybe a 50.
50.
50. We have a 50.
2.75.
Free and it's a tapering stent. You have a tapering stent. Free 2.550. Free 2.550. Yeah, that will be the best. 16, 50. 50.
Hmm.
50. Yeah. So basically, this stent is
Metal.
made by Merrill. It is a long stent. It is a tapered stent. So the proximal end is 3 and the distal is 2.5. The advantage is that it will be only one stent. So one, that it will bring down the cost. Two, that there will be no overlap area. And three, that it makes things much faster and easier. So that is the advantage. And it's always known that, rather than two overlapping stents, one single stent is always better. And since in these kind of situations, the the vessels are tapered from proximal to distal, that is why a tapered stent is a good idea. Yeah, we have a length. The stent lengths of these tapered stents are somewhere in the range from 50 to 60. So they come in 50 length and then 60 length, and then they have various kind of permutation combinations like 2.75, 2.25, 3 and 2.5,
Yeah.
and then 3.5 and 3. Okay. Now, check. Not really. This diagonal is a very nicely, flowing vessel with good osteal, no major disease in both the septal and the diagonal. So I'm not too much bothered. Ariocaudal, please. So we'll position this stent in the ariocaudal. Okay. Okay. Check, please. So the good part is that the stent also costs the same as a normal stent, so it's not expensive, and that is the advantage that we can. I think we'll have to pull a little bit
Yes.
because there is a space there.
Yes.
Check, please. Yeah,
Yes.
this is fine. Check again. Yeah, maybe a little bit.
No, sir. It's fine.
It's fine. Just
Distally adjust.
okay. Check, please. Yeah, go up. 1, 2, 3, 4, 5, 6, 7, 8, Okay, so the expansion has happened at 8 atmospheres epicranial, and you can see that the proximal edge is appearing bigger than the distal edge because it is a tapered stent, 3 2.5. Okay, and the expansion is good because we did a good amount of dilatation with cutting balloons at high pressures. Deflate, please. So it prepared the lesion bed reasonably well, and so this was up to 8 atmospheres.
Yes.
Okay, and the nominal is go up 1, 2, 3, 4, 5,
9.
6, 7, 8, 9, 10, 11. Okay, deflate. So the nominal is 9.
9.
Okay, we went up to 11. That's it. And bus. Okay, okay, okay. Yeah, so we have to use two balloons in case we have to do a high inflation. We have to use two stents. Okay, two balloons. Sorry. One will be for the distal part, which is like, so we'll choose with the distal reference and the proximal reference, and he will now check. Yeah, you saw that the balloons, the both the branches are flowing very well, and the distal part is also looking good. The proximal is very good, and we are very happy now. Post stenting FFR we can do because we have the FFR wire here, and but I'm just doing a IVUS first to see whether we need to do any post dilatations. Typically, we use iohexol, and which is coming by the name of Xenetix here in our lab. And in some patients who have low EF or renal issues, we preferably use this one ioversol, which is coming
Low
by the name of
molecular. Oh, Visiback.
Visipac. Okay, so pull back. So now you can have a look at the IVUS. So the distal margin is very good. Stent is fully expanded. Lumen is good. We really don't need to do any post expansion here where we are. Okay, so we are at the bifurcation, and even the proximal looks great to me. Yeah, it's quite nice.
Landing is also
So here we can do some dilatation with a 3 mm balloon because there's some little bit of stents hanging there. Stent starts. I'll take a 3 mm balloon and do the post dilatation. So the cutting balloon has to be taken as in the distal reference segment because we have to really respect the vessel diameters in cutting balloon, and if you don't do that, the chance of having a rupture or perforation is very high. So we have to really go by the distal reference diameter, especially in cases of long lesions.
Check.
And do not oversize
Negative.
at all. Never oversize the cutting balloon ever. Okay. Go up. 2, 4, 6, 8, 9, 10. Okay, deflate. So we have done the dilatation with a 3 mm balloon in the distal segment first, and then we will go to slightly higher pressures here because this is a segment which is having a good size. Go up 2, 3, 4, and you can see on the stent boost. This is a online stent boost from Volcano. How much? 12?
Yes.
14. Okay, deflate. Okay, so stent looks very well expanded. Yeah. Okay, so we are at the upper edge. Yeah, we are a little bit out. So I can see that. Yeah. Okay. Go up. 2, 4, 6, 8, 9, 10, 12, 14, 16. Deflate. RO caudal, please. RO caudal. So
Yes.
I can see the edge is fine. Go up. 2, 4, 6, 8, 10, 12, 14, 16. Deflate. I think we are done on this artery.
2.5 cutting.
Okay. So we can take a shoot here if required. Okay. And this
Yes.
looks nice. Yeah. So both all the branches are flowing nicely. The proximal edge is okay, and the distal edge is okay. So we don't need to do any further dilatations. We are done. So I'll take this wire out. Okay. Yeah. So this is pretty much done. Come to areocranial because I want to put this wire into that big branch. This is the FFR wire for just to make you again aware that we had put a FFR wire in the OM in the circumflex. Check please. And
Yes,
the
sir.
OM FFR to OM was negative. Check. Okay. Okay. No.
Mm.
uh,
Yes.
Okay, fine. So let's come back to the RO caudal, and now we can disconnect the FFR wire, and you can see again that the IFR is very positive, zero point 0.7. So we need to treat this. So I'm just taking it off. Okay, fine. Give me a balloon, please. 2.25.
We'll directly go for cutting or
Directly cutting may not cross it because, as I
yes,
said, that it is a. Show me the
here
first angio. I mean, we can try, but sometimes it may not. What is this? A
cutting.
cutting balloon?
Yes.
It's a cutting balloon 2.5. So since we already have a cutting balloon, Wolverine 2.5, 15. I'm just using that. Same one. RS.
Center.
Position central, please. Check, please. Okay. So it is going gradually. Okay. Go up. 1, 2, 3, 4, 5, 6. Okay. So I won't go to high pressures here.
Yes.
So it has given up at 6. Very nice. Deflate. Okay. 1, 2, 3, 4, 4. Okay. 5. Deflate. I think we have done it. Yeah. Can you check now? So we have done these two dilatations here. Oh, this looks nice.
Small,
Huh? What?
slightly further,
Oh,
sir, till the tip.
oh, okay. Okay.
Yeah.
1, 2, 3, 4. I will be a little gentle here because it is a distal segment of the vessel. Okay. 5. Deflate.
Slightly further.
No, that's fine. Okay. Go up. 1, 2, 3, 4. 5, 6. Okay. Deflate. So these are overlapping inflations using a cutting balloon. Okay, check please. Yeah, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9.
2.535
Deflate.
solution.
So this is a 15 millimeter balloon. 2.5, 15. Wolverine dilatations have been done in overlapping segments, and we are now heading to,
We'll just need to check FFR.
yeah, I'll just check it. Okay, that looks very nice actually. Yeah. In fact, there is no distal major dissection. The artery looks very well dilated. So I think I will go with a balloon
FFR पे आना.
DEB.
FFR.
Let's check the FFR now. IFR, please. Yeah. So this is phenomenal. The IFR has improved from 0.7 to
It's all
8.82, which is much better, 8.3. And so the values are much better now.
0.83.
How much? 0.83, 0.85. Okay, let's give some nitro, please. Mhm. Yes.
Preservation of side branches seems able to taper long distance.
Yes. So yeah, this question, somebody put up that, what about the side branches? So let me tell you, this tapered stent, which is the one which we use, the Merrill Morph stent, and it has an open cell design. So that is why the,
30 के बाद.
the side branches are very well preserved, and these patients do very well with it.
35, 40.
40. 40 is fine. So we can take a 40. So I'm taking a 40 millimeter drug eluting balloon, which is a 2.540 solution, which comes from Medalliance. And you can see that, this vessel has opened up reasonably well, and I'm not inclined to put a stent over here. So distally into the circulation.
Now it is 0.93.
Yeah, now it is 0.93. Look at that. 0.93, 0.94. So I'm very satisfied with the IFR values post dilatation. And this is one, very positive thing which we can achieve by doing good plaque modification using sometimes IVL, using sometimes cutting balloons. But as you saw here in this fibrotic lesion, use of Wolverine was very, very exceptional. You should give me a
They have 2
drug
points.
eluting balloon.
If company trying to get this super stent to US, we can benefit from this outstanding stent.
Yes, yes, certainly. I think, Merrill is registering there, and we will check with the company. They can contact or find out. But definitely, this is a very helpful thing, very quick and very nice.
Magic.
Yes, on angiographically, it was looking like 70% at least with such a long branch. But when we did the FFR, it was negative.
So we have
Yeah, so we have, so 3 will be too much, and we can take a, 2.7540, 2.7540.
2.7535 be a solution.
No, 2.7535. But 35
35.
may be a little short, I
Okay.
think. Or we can take a 2.25 and go to a little higher pressures. It can become too high. So give me a 2.25.
No, this is 35 in
No.
solution. Magic touch 2.25, 40.
40. Give me a 40. So I'm taking a 2.25 40 millimeter balloon.
Size of tab out.
The size of deb has to be selected almost 1:1, and in terms of diameter selection, and then length also, you have to cover the entire length. There is no problem. So here you can see it's a long lesion. I'm going to take a 40 millimeter balloon, and so now I will disconnect again, and the IFR was 0.94. post dilatation, which is what we want after any intervention.
PCT check now.
So this is 2.25 into 40. Yeah. Okay. Yeah. So we are on the same wire, which was the FFR wire, and doing the whole intervention on the same wire. Okay. I think we are fine.
Yes.
Okay. We can check again a little bit. Yeah. Okay. Go up, please. 2, 4, 6, 8, 10. Okay. So now this is you can remove it so that we see it a little bit better. Yeah, you can see that it's a balloon 2.2540, which has been inflated up to 10 atmospheres. We can go up to 12. 12, please. 12. Okay. So we'll keep it for about 1 to 2 minutes. If she can tolerate, we'll go up to 2 minutes. And our results with the long drug-eluting balloons has been quite nice. And especially when we see stent-like results after balloon dilatations, we just don't put stents. And in this lady also, somebody may ask, why didn't we put a drug-eluting balloon? The plan was to do a drug-eluting balloon, but since we saw that dissection in the mid part, which was like appearing to be, occluding the lumen a little bit, so we decided to stent it. So here we are with the dilatation. 1 minute's done. Patient is tolerating it.
So in this case, sir, FFR made a good tool for us for
Yes.
continuing this observation of
So
expansion.
it is not just diagnosis, it is continued FFR helping us to decide at every stage whether we need to put a stent or we can just do a drug-eluting balloon. Okay.
Saving contrast, saving radiations.
So all the cases where we do drug-eluting balloons, we have the same strategy. You have to do a good plaque modification, get a stent-like result, and then do a drug-eluting balloon. And sometimes we have to do a, like in this case OM, the plan was to do a cutting balloon and DEB if it was positive, but it was not positive. Okay.
Negative.
Okay, we are 2 minutes done. Deflate, please. Deflate. Yeah.
Preferred techniques for small and diffuse idiopathic presence.
Yeah, so if the vessel is long, diffuse, small, or even in bigger vessels, if the patient is young,
FFR.
FFR. And if the the disease is diffuse, or if the patient has high bleeding risk, in these patients we do a drug-eluting balloon.
Remove this first.
So I'm taking this 40 millimeter balloon out, and it comes off easily, no problems. And the drug is delivered at the site. Okay, and we can now check again, finally, with the same wire here connected, and we'll look at the
NTG.
Yes. So we have 2-3 types of drug-eluting balloons here. What is this? Nitro?
NTG. Yeah.
Okay. So one, we have the Magic Touch, which comes from an Indian company, Concept Medical, which is also a sirolimus eluting balloon. Then we have a paclitaxel eluting balloon, which comes from iVascular. And then we also have Sequent, please, which is a paclitaxel eluting balloon. But let me tell you, our dominant balloon usage today is sirolimus eluting balloons. So this looks quite nice to me. And with this long balloon, the result is quite nice. And the vessel flow is good. We don't see any major dissections. So I think we can leave it.
Yes.
Yeah. In instant restenosis, definitely. This is one of the indications where we do not use anything except regulating balloons. And where we also do the same thing. We do a cutting balloon. Sometimes we do a laser also in these cases if it is a diffuse instant restenosis, and then laser followed by cutting balloon and followed by a drug-eluting balloon is the strategy which we take in many patients. In the last, I think, midstream, we showed the use of laser plus cutting balloon and DEB. So I think we are done. The IFR value is above 0.9, as you can see here, 0.92. And so it is nice. We will take the wire out. Okay. Yeah. And with this, I think we don't need to do anything further. Show me the last shot, please. Last shot. Yeah. So the LED is looking fine. And we can take another shot of the LED if you want. AP can. Yeah, in fact, I see that the only shortcoming is
Epicranial.
if in case the dissection is significant, then you cannot use a DEB. But if the dissection is up to type 2 dissection, I don't really worry about it. And up to type 2 or type B, type C dissections, there is no problem. Okay. So everything looks good. And you can see that the circumflex is looking very good now. There is a minor dissection which will heal up on its own. Okay. So I will take this everything out, and all the vessels are flowing nicely. There is no issues. No, so we didn't go up that high. So we did. So somebody asked this question whether the plaque may shifted to the OM. Actually, we didn't go up that high, and we were only in beyond the OM, so that part was okay. So we are done here, and the result you saw, we are very happy, and thank you very much. And I hope to see you again next week. All the best. Bye bye.